Hello, everyone, and welcome to today's webinar, Knowledge is Power, Unveiling Women's Vaginal and Sexual Health Insights. I'm Christina Jewell of LabRoots, and I'll be your moderator for today's event. Today's educational web seminar is presented by LabRoots and brought to you by Thermo Fisher Scientific. To learn more about our sponsor, please visit thermofisher.com. Before we begin, I would like to remind everyone that today's event is interactive. You can submit as many questions as you want at any time you want during the presentation. To do so, simply type them into the Ask a Question box and click Send. I would now like to welcome our speaker, Dr. Olivia Van Gerwen, Assistant Professor, Infectious Diseases Division, UAB. For a complete biography on our speaker, please visit the Presenter tab. Welcome, Dr. Van Gerwen. You may now begin your presentation.
Thank you so much. As she said, my name is Olivia Van Gerwen, and I'll be talking to you all today about vaginal and sexual health issues facing cisgender women. To begin, I do receive research and grant support from the NIH, Abbott, Molecular, Gilead, Visby, and BioNTech. I've also done some advisory work and consulting work for the entities listed here. And I do want to thank my colleague, Christina Musney, who I do a lot of this work with. I run a vaginal health clinic here at UAB with her. She and I co-developed these slides, and she has shared them so graciously with me for this presentation. And I do want to acknowledge that I was given an honorarium for giving this talk. So today I'd like to go through a couple of learning objectives, and these are very much focused on clinical care and diagnostics in the space of vaginal health for cisgender women. So at the end of today's talk, I'd like to have y'all be able to distinguish between clinical features of common causes of vaginitis that's infectious. So BV, Trichomoniasis, Vulvovaginal candidiasis are the big three. I'd like to give you information that will help you evaluate a patient who's presenting with vaginal symptoms. And this will be through the use of physical exam, but also various diagnostics, including point of care tests and laboratory assessments. And then finally, we want to understand the molecular diagnostics that are currently available to evaluate vaginal symptoms. To begin, I want to begin with a paper that I'm going to talk through a little bit that gives you a process and an algorithm when, as a clinician, we're seeing these patients who present with vaginal symptoms. So as I mentioned, I am at UAB in Birmingham, Alabama. I'm an infectious diseases doctor, but a lot of my expertise and my interest is in sexual health and vaginal health. And part of that is collaborating with women's healthcare providers such as OB-GYNs. And we began in our infectious diseases division, my colleague Christina Musney and I, a vaginitis specialty clinic where we take care of these issues on a consulting basis. So if they're seeing their primary OB-GYN and they can't seem to figure out what's going on or how to fix the problem, they will send them to us so that we can, potentially deal with some of these more complicated entities. And so one thing that's really helpful to me is having an algorithm and a process for figuring out the root cause and the approach to treating the problem. And I think this paper is really helpful. So Reichman et al. Describes 6 principles that we need to accurately diagnose women when they're experiencing vulvovaginal symptoms, including genital discomfort. And so it's pretty consistent with most of the things we learn in medicine about, pinning down what is causing a symptom. You want to figure out where it's coming from. You want to make sure that you're dealing with one problem, and if you're not, how many other problems and what they are. So a common theme that we'll see throughout this talk is, women who have vaginal symptoms often have more than one process going on at the same time. And if you're unable to treat all of the issues that are going on, you may not be able to give them the relief they're seeking. And then when you have multiple problems, you want to evaluate those each separately. And we'll go through that in a minute. And then the last 3 pieces of this principle diagram are talking about using point of care testing like wet mount and pH, which we'll talk about, following patients closely, and then figuring out what to do when you can't get them to respond to your first line treatments. So I won't belabor these kind of complex algorithms, but using things at the point of care like pH can really help you get a sense of what direction to go in when you're diagnosing someone with these vaginal discomfort complaints, such as pain with sex, pain in general, itching, and discharge. A lower pH indicates that there is, less of a anaerobic organism presence and potentially more lactobacillus present in the vaginal microbiome. And you can assess that with pH paper. And then once you have a result, if they have a discharge that demonstrates a normal pH, you're thinking about things that are more in line with vaginal candidiasis or a yeast infection. People can have a physiologic discharge, which is this physiologic leukorrhea that you see here. And then people can also have things like contact dermatitis related to things that they have been exposed to. If they don't have these symptoms, there's a potential to have other infections that we will talk about later on. With high pH, again, we are concerned typically about things like bacterial vaginosis, trichomoniasis, and potentially non-infectious causes related to exposures like vaginal blood, if people have pooling of the blood in the vaginal vault after menses, douching, things like that, foreign body retention. And usually the symptom that people are going to have when they have a high pH is going to be malodor of the genital tract. So again, there's a very wide differential here, and I'm going to go through some of this, but I found this as a helpful place to start in clinical evaluation. And itching is another symptom that's very common in terms of vaginal health. People will come to us all the time as a referral. We're an infectious diseases clinic, so they will send us someone who has a yeast infection that's unable to be treated. And that's usually what people will say is the cause of an itching symptom in the genital or vaginal tract. However, as you can see, there's a really extensive list of differential diagnoses for people who experience genital itching. So it's not always yeast. A lot of times, since we are not obstetrics and gynecology, we're unable to do things like biopsies in our clinic. And we are not expert in, kind of distinguishing some of these various skin conditions. But we do have a good referral network where we can send folks. But all that to say, there are a lot of different causes of vaginal itching, vaginal symptoms that are non-infectious. Today, I'm going to focus on the 3 top causes of vaginal odor, itching, discharge that are related to infections, and I'll have a little bit at the end about some non-infectious causes, but this is just kind of a broad scope. Again, anatomical diagnoses, anatomical location of the lesions and the symptoms can be really helpful when you're coming up with a diagnosis, beginning with the vulva, which is the outer part of the vagina, like the labia, and then vestibule being the part inside of the labia, but prior to getting into the vaginal canal, and then finally up into the upper tract to the cervix. So after that broad overview, I'm going to start by talking about vulvovaginal candidiasis, also called VVC, and then, more colloquial known as a yeast infection. So this is the second most common cause of vaginal symptoms worldwide. Candida species, which are what cause this condition, are commonly found as a colonizer in the lower genital tract in many women and people. So 10 to 20% of healthy reproductive age women will have this just as a colonizing organism hanging out, not causing any problems. However, this is a very impactful diagnosis that results in a lot of outpatient visits in the clinical setting, and then the treatment cost is also very high. So this is of interest for sure in terms of healthcare cost. And there are lots of risk factors that can make this a problem that is not just a innocent bystanding colonizing organism. So, people who are on antibiotics, people who have depressed immune function for whatever reason, be that HIV, chemotherapy, uncontrolled diabetes, also people with fluctuating estrogen levels, such as pregnant people, people who are on estrogen therapy, all can be predisposed to having issues with vaginal candidiasis and yeast infections. I have here genetics as well. Some people are just genetically predisposed to having these issues. And then, of course, iatrogenic, meaning doctors do something to a patient that makes them have this. So if you, again, get diabetes, that is not well controlled, if you have antibiotics on board, all of those things could lead to potentially having this condition. So on presentation, we typically see pictures like these over here. The top one is of a speculum exam in the vaginal vault. You see this thick discharge, which is white and kind of adherent to the walls of the tissues. And it is always described as cottage cheese-like. In terms of how the skin is affected, we usually see pretty angry-looking erythematous and edematous skin in the vulva, vestibule, and vaginal canal. And because it's so itchy, there's often some excoriations or fissures that are seen. Patients will tell you that they have itching, burning, soreness, irritation. With that, they have pain with urination, pain with sex. And then, of course, I mentioned the vaginal discharge and the characteristics of that. And often this is worse before menses, but some people, as I mentioned, hormones can play into your susceptibility to this. Some people will have it worse after menses. It kind of is individual, but hormones can certainly impact how people present. So the way we diagnose this has evolved a lot over the last several years. I've been in practice for about 10 years now out of medical school. And when I was in medical school, the primary thing that we used to diagnose this was point of care testing via wet mount microscopy. And we still use this a lot, but we've come a long way. So point of care diagnostics often are used in clinical settings where you can have a microscope, you can have a clinician who can read these things. So you take a slide, you take a vaginal swab and you put it onto the slide and then put saline on top of it. And then you look under the microscope where you're able to visualize either budding yeast, which you can see in this top right picture. You can see the little buds there, or pseudohyphae, which are the more strand, classic appearing fungal elements. They're more difficult to see on the plain wet mount, but you can amplify your ability to see them if you add KOH to the solution of saline on your wet mount. That's what's pictured at the bottom here. And typically these people, as I showed in the other slide, have a normal pH and they don't have a positive whiff test, which when you put KOH with a vaginal fluid sample, if they generate an amine odor, which kind of smells like salmon or fish, that is called a positive whiff test, and that's indicative of some kind of process like BV. The whiff test will be negative with people who have yeast. So at the point of care, in a lot of cases, you can see this, especially when people are symptomatic. But as you can see, the sensitivity of this test is not great. Only 40% of pseudohyphae are seen on wet mount. Sometimes it can be difficult to distinguish budding yeast from things like mononuclear cells, white red blood cells, things like that. And then with the KOH, again, the sensitivity is better, but it's not perfect. Culture is a very important piece of our diagnostic patchwork that we use in our clinic. So it is obviously able to identify the specific species that you're dealing with of Candida. It's a gold standard diagnostic because if you grow it, it's there. And it can be useful in a lot of settings, and we'll talk about this in a minute in terms of treatment. It can be really useful because you can get susceptibility testing performed in some labs. This is a very limited resource. We do it here at UAB. I think we're one of the few institutions that does it, but there are fungal reference labs that will perform susceptibility testing so that you can see if the various agents that we like to use are going to work for your patient. Of course, with culture techniques, these take time. So usually cultures take between 48 and 72 hours of growth for you to have all the information you need. And that's just at the species level. It takes a little bit longer to get the drug susceptibility testing back, especially if you're sending it out to a reference lab. So that is a drawback for sure, but it can be useful. Vaginal gram staining is something we use in research, but we don't really use in terms of clinical care, especially with yeast. So as far as epidemiology goes, microbiologically, the most common, far and away the most common type of infection that we see with VVC is albicans. So the species Candida albicans is responsible for 85 to 95% of infections based on this literature here. And the non-albican species make up the rest, with glabrata, cruzii, pyropsilosis, and tropicalis being the ones we see. I've seen a few others, but very minor. And most of these people who have these unusual species are going to have recurrence of their infection. the one-off people who have, an episode of VVC and then they never have it again, usually those are going to be people with albicans. And we'll talk about treatment in a minute, but it's important to know that glabrata and Krusei have very limited treatment options because they cannot always be treated with azole therapy successfully. And that'll become clear why that's important in a few slides. As I mentioned, we've come a long way in terms of what kinds of diagnostics we have for this issue. There are molecular diagnostics available for testing for the presence of yeast. There are 3, when I made these slides, there were 3 FDA-approved PCR tests that will run on vaginal specimens and can detect Candida species. They're all qualitative, so they'll say like this species is here, this species is not here. They don't give kind of amounts or fungal susceptibility data. All of them are able to show you the species listed here, and some of them that are available commercially can identify Candida krusei. Some of them will identify, like they'll say C. glabrata / krusei, so they won't distinguish between the two, but they will say like it's one of these. And that's important, as I mentioned, for treatment because those 2 in particular are unable to be treated with azole medications. And, as I mentioned, this is a fairly new diagnostic in terms of availability. It has been, very helpful in clinical practice. A lot of times people will come in and they'll have a symptom and we'll say, oh, that's yeast. And based on how the patient looks. And this study that was done in 2021, they found that a lot of people who the clinical diagnosis of yeast was made and then the diagnostic with the molecular testing was negative. And then the opposite was also true. There were many people who were assessed. They were said they do not have vaginal candidiasis based on their clinical assessment, but the test ended up being positive. So these really can truly find the presence of these infections in a lot of cases. And it is going to help, one, to improve our accuracy in diagnosing patients, but also it's a good stewardship initiative in that if we're able to say this is not yeast, we may avoid the use of azole therapy, which coming on to my next couple slides is very important given the limited treatment options that we have for this entity. So treatment of uncomplicated VVC, so just an acute episode that's mild. Usually it's going to be in people who are normal immune system with Candida albicans species. According to the CDC treatment guidelines from 2021, you'll notice that every single one of these is from the azole drug class. So one drug class, when we think about that, it's very, very disheartening as there are often times where people have resistance or have issues tolerating these medications. So one thing that really is lacking in this area is therapeutics. So there are topical agents that we can use in these settings. And then there's, of course, one oral agent, which is fluconazole. And as I mentioned and have alluded to, there is a problem with resistance, and it's an emerging problem. This is similar to a lot of different microbes and concerns in terms of antimicrobial resistance. Non-Candida species, as I mentioned, are common in people who fail treatment and have resistance. And Candida albicans has always been thought of as something that's very, very susceptible to azoles in the inpatient setting. I often will attend on our inpatient infectious diseases consult service. And if someone has Candida albicans in the blood or somewhere else in their body, it's like 99% of the time going to be susceptible to an azole. However, in these vaginal specimens, we're seeing more and more resistance due to the very, very robust community exposure to this medication. There's a lot of people who will just call their doctor and be like, I have a yeast infection, and they'll get an azole, and they just do this like month after month, year after year. And that in conjunction with people who have recurrent issues and are put on long courses of azoles has led to a steady uptick in fluconazole resistant vaginitis cases. This is a bit of an older study, but it's already kind of telling, between 2000 and 2010, you can see there's a trend going toward more resistance in the community. How we treat this. So as I mentioned, it's really important to make sure that the yeast is causing the problem. So yeast colonizes many women. If someone is having a vaginal symptom, it may or may not be related to the candida. So really important to tease that out with your diagnostics and with your history. Susceptibility testing can be really helpful as well. And then you want to determine your treatment regimen. And as I already showed you from that slide before, there are very limited options from the CDC that are FDA approved. So when people come to me, I'm often, kind of cobbling things together based on the limited data that exists for other treatments. When we're talking about azole-resistant Candida albicans, you can use these other azoles that I have listed here. However, they often have some cross-resistance. If they're resistant to fluconazole, they'll probably have some degree of resistance to ketoconazole, posaconazole, voriconazole. And these medicines also have a lot of toxicity compared to fluconazole. As I mentioned, topical azoles may be an option for some people, but there's not a lot of efficacy data for those. One thing I use a lot of is boric acid intravaginally. So boric acid is a biofilm disruptor. It is administered intravaginally and can be made into a suppository or a little ovule. I always actually will get it compounded by a pharmacy because most preparations of boric acid are available over the counter. You can buy them on, in grocery stores, online, and these are not regulated and these are impossible to know like what is in them. So if you use a compounding pharmacy, you have a little more certainty that they're getting quality product. But if you have something that's resistant or is failing treatment with typical azole therapy, using a 14-day course of boric acid can be very helpful. I actually saw someone on Friday that I cured with this. And again, this is a nice paper that Jack Sobel, who's one of the experts in this area, published about how to treat these issues. There are a couple of new novel therapeutics that are really giving me hope for the way that we can treat people who have these problems. Ibrexafungerp is a novel orally active triterpenoid antifungal, and so it kind of works like an echinocandin, which is like micafungin. And it has a broad range of in vitro activity against Candida isolates, including resistant isolates. So they've studied it in Candida albicans VVC, both in acute and in recurrent cases, and it's shown pretty good efficacy both in and of itself and with resistant isolates because it's in a different drug class. And it's also been compared to fluconazole and shown good efficacy in terms of mycologic eradication. So I already mentioned non-albicans VVC. This is a very difficult thing to treat. There's been some analyses kind of showing prevalence of this. It's not uncommon. As you can see, this one tertiary care center in this 2016 publication, 29 out of 55 isolates were Candida glabrata, 16 were Propsilosis. We're seeing these quite often. And then boric acid was used in a lot of these cases and was successful. So that's where we get that recommendation, is from studies like these. Boric acid was effective in this other study where they looked at symptomatic people with Propsilosis. And then the optimal treatment we don't really know what it is because, again, there's limited data here. But we usually err on the side of longer courses of therapy in these patients. 7 to 14 days is what we typically recommend. I even do 21 days sometimes, depending on what the patient's treatment history has been. And, if you have a recurrence, you can try these longer courses of boric acid as well. One thing I will say about boric acid that's really important is it is an intravaginal medication. It doesn't have a lot of systemic absorption, but it is not studied in pregnancy, so we don't give it in pregnancy. It can be used in breastfeeding, as far as I know, because it is a topical medication, but it is important to counsel patients when they are using this to not have oral sex performed on them and to not ingest the product because it is caustic and can cause very serious effects. And I believe there have been deaths reported with that. So recurrent vulvovaginal candidiasis is actually probably the thing I see the most of in our vaginitis specialty clinic. It's defined as 3 or more symptomatic episodes of VVC in a 12-month period. It's extremely common. This survey-based data here show that Self-reported prevalence is 9% in Europe and the US, and this is mostly in women ages 25 to 34. It's an extremely costly issue. People are missing work, going to the doctor, taking medication. It's very, very taxing on the healthcare system, and there just aren't a lot of good options for it, as I've already mentioned. So I already mentioned as well that this is seen in not uncommonly with non-albicans species causing the issue. And the reason this happens, we've already talked about some of the things that could predispose you to both an acute vulvovaginal candidiasis episode, but also recurrence. So if you have an ongoing immunosuppressing condition like diabetes, like HIV, certainly you could be at risk. So host factors are important. And then frequent antibiotic use is extremely common. I know many of you probably know people who say, every time I take an antibiotic, I get a yeast infection. And I can't tell you how many patients I see in the hospital that I give antibiotics to that tell me that. So there are thoughts that potentially genetic predisposition could lead to people having recurrences. But also one thing I see a lot of is people come in and they have these recurrent episodes, and it's because no one's ever done a susceptibility test on their isolate of yeast, and they are resistant. So they've been having fluconazole after fluconazole treatment, and fluconazole is not effective against their specific isolate. Also, people can sometimes be underdosed on treatment regimens. A lot of these vaginal conditions, the treatment is very dose dependent. So if you just have the treatment regimen that most people get for acute vulvovaginal candidiasis is a one-time dose of 150 milligrams of fluconazole. Some people need 3 doses 3 days apart each. And so underdosing can certainly be a problem. So the treatment is not really well described, but the current recommendations are a longer duration of azole therapy if you're able to do it. So 7 to 14 days of topical therapy with something like miconazole or turconazole, or this every 3-day, 3-dose fluconazole regimen I mentioned. And then after you treat their acute episode, you put them on a maintenance regimen so that they can, kind of keep the symptoms at bay. And this has been shown in some studies to decrease the number of days with symptoms. This can make people less likely to have a recurrence if they are on a 6-month regimen of weekly fluconazole. Again, there are some hopeful candidates for treatment. Oteseconazole is a new agent that it's already approved and it's being used for recurrent VVC. There's an FDA approval indication for it. It's got a pretty long-acting profile. However, it is only for use in people who are not of reproductive potential. There's some pretty significant teratogenic issues with this medication. So you can only give it to people who've had a hysterectomy or a bilateral tubal ligation. They don't even recommend giving it to people with reliable birth control other than those. And then ibrexafungerp, as I mentioned, has also been studied in recurrent VVC and has been shown to be efficacious. Pregnancy, of course, I mentioned hormones can really impact someone's susceptibility to having a vaginal yeast infection. Oral fluconazole is not recommended in pregnant women. There are some studies that I show here that show its associations with spontaneous abortion and with some cardiac abnormalities in infants. These are studies that are observational registry-based studies, and I think it depends on the doctor. There are many doctors who will do short courses of fluconazole orally for pregnant patients in certain trimesters. Again, I'm not an obstetrician, so I can't speak to those practices, but the recommendations in most of the societies is to err on the side of caution and use topical agents throughout pregnancy, given these risks. So that was yeast. I'm going to shift gears a little bit and talk about Trichomoniasis, which is another very common cause of vaginal discharge, and it's a sexually transmitted infection. So global prevalence of Trichomonas is extremely high. I think it's always surprising to people when I give talks about this because I think people don't think about Trichomonas very much. But as you can see on this slide, the blue bars on top represent Trichomonas and the blue bars on bottom, again, also represent Trichomonas. In women, Trichomonas is extremely common, especially in low-income populations. It's got a prevalence of 5.3% globally from this 2019 publication from the WHO. In the US, it's also very common in women, 1.8% prevalence in this study where they did highly sensitive NAT testing to look for the prevalence in this population, much higher in women and much higher in women who are Black or women who have had some of these other social kind of determinants in their reporting in the study. Unclear what that means or where that comes from, but it seems like there's a lot of social determinants at play with the high prevalence of T. vaginalis in these populations. And it's more common in the US than in some other high income countries like the UK. I think for a long time, people have thought Trichomonas is kind of an inconsequential infection. You know, it causes some discharge, blah, 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 whatever. But it actually has, in recent years, become pretty clear that there are lots of consequences, especially for women. It is associated with several adverse birth outcomes. It has an increased risk of HIV acquisition if you have an active Trichomonas infection. HPV and cervical cancer have been associated, as well as some other surgical and post-surgical and gynecologic conditions. And then in men, it causes, obviously the symptoms of urethritis, penile dysuria, and it has this increased risk of HIV acquisition. And of course, men are a reservoir for women in heterosexual couples, so it can certainly be important in that regard as well. So when we see people, they typically present with a kind of greenish, yellowish, frothy-ish vaginal discharge, which you can see here. And you can also see strawberry cervix, which is like a speckled cervix on your speculum exam. But typically people present with, as I said, vaginal discharge. Diagnostics, again, the wet mount can be really useful. All three conditions I'm going to talk about that are infections, we use the wet mount microscopy regularly. So I wish I had a video here, but I don't. You can see Trichomonas on a wet mount. It is very, very specific because it looks like a little, it's the one at about 12 o'clock here, the one that looks like a teardrop. They're flagellate organisms that move around under the microscope lens, and you can see their little flagella moving when they're in the saline. However, they need to live at like 37 degrees Celsius. So once you do the exam, you have a short amount of time before you lose the ability to see them on wet mount and they lose viability. So you must perform this test really quickly, and the sensitivity is not great. So if they don't have a high parasite burden, you may not see them, and they are, you have to look at many, many fields sometimes to find them. So the sensitivity of this test is not great. Another test we use is the culture of Trichomonas. It has a special medium that we use. Again, this organism is it likes warm, moist places. And so if you have it in ambient temperature, it can die. So getting it into the culture medium within an hour of specimen collection is really important. And then you have to incubate it at 37. Again, the sensitivity is like slightly better, but it's not great. And then only certain labs do this. And the other benefit of doing this culture is you can get susceptibility testing results with it. But again, only certain labs do that. We do it here at UAB, and the CDC also does it. There are point of care antigen tests. These look very familiar to all of us, I know. They look kind of like COVID tests or pregnancy tests. They can be performed on vaginal secretions, and they detect protein antigens. They have quick results in about 10 minutes with much better sensitivity and specificity. However, they're not validated in men. They're not really widely used in the US. The thing we use mostly are going to be this slide and the next slide. So we do a lot of molecular diagnostics for Trich now. You can do qualitative detection of Trich DNA from some of these molecular amplified assays. To be honest, I'm not as familiar with this one as I am with the ones on the next slide, but they have quicker results and are sensitive and specific. The nucleic acid amplification tests really are the gold standard for diagnosis these days. They're highly available now. Many clinical settings use this instrument-free or the FDA-approved NATs that are run on a big instrument panel. So the second line here, so you get a swab, you send it to the lab, they run it on one of these big NAT panels like they do COVID tests on, and they're highly sensitive and specific. There are several different assays that are validated by the FDA, and they're often multiplex with other STIs. Like several of them will be, you get one swab and it can run chlamydia, gonorrhea, trichomonas, etc. And the top little section here is interesting. There's a new test that one company makes that is instrument free. So they give like one-time use devices that are used in the clinic, and they are single use. They do PCR right on the little device that's about the size of a cell phone. And they can do point of care PCR detection of multiple STIs in less than 30 minutes. Those are pretty interesting and, kind of the future of what we're going for in diagnostics. So treatment for STI or for T. vaginalis from the STI treatment guidelines currently are for metronidazole. For men, we recommend a single dose of metronidazole, 2 grams, and then for women, 500 milligrams orally 2 times daily for 7 days. This is because they've done studies in women and they've shown that it is superior in women to treat with 7 days compared to 1 day of a single dose. In this study that was done here at UAB and in Louisiana, we found that people were adherent to this treatment and they had better outcomes and higher likelihood of cure with the 7-day course of treatment. So this is just another slide showing that adherence was good and tolerance was actually good with this medication as well. There are new medications on the pipe for Trich as well. Secnidazole is in the same drug class as Trichomonas, and it is going to be available for you can do directly of their therapy for it because it's a one-time dose, and it is efficacious in treating both this and BV. It's approved by the FDA in men and women, so that's nice. Following up these folks, you want to treat them and then you retest them about 3 months after their initial treatment, regardless of whether or not their partners were treated. Of course, with this infection, since it's an STI, you want to ensure that your partners are also getting treated. And then if retest isn't possible, you want to test them at some point in the next 12 months. So that's Trichomonas. I'm going to move on to BV. And I'm sorry for our presenting facilitators. I'm getting a message push to audience instead of next. Is that correct? Is everyone seeing my slides?
No, make sure you push to audience and use the next button.
Oh, okay. So I'm sorry if y'all didn't see my last few slides.
Perfect. Thank you.
I'm just going to go and show these real quick. So I think we missed these. These are just describing what I talked about with the treatment of Trich, as well as the follow-up. So now, apologies for that. Moving on to bacterial vaginosis. This is a lovely picture of a clue cell, which I'll tell you about in just a minute. So BV is the most common cause of vaginal discharge worldwide. There's a huge burden of disease, and the treatment burden costs a lot of money. It's very common in both non-pregnant and pregnant women all around the world, 27% prevalence in the US. So, or 30% per this data set. It's associated with a lot of the same things as Trichomonas: low birth weight, adverse birth outcomes, increased risk of acquisition and transmission of STIs and HIV. So it is kind of a little bit different than these other entities, which, there's a germ and a syndrome, yeast causes VVC, Trich causes trichomoniasis. BV is a little bit different because it's a dysbiosis. It's not one germ causing an infectious syndrome. It's characterized by a decrease in lactate-producing lactobacilli, which are kind of the healthy vaginal microbiota, and then an increase in anaerobic organisms such as Prevotella, Gardnerella, all these different BV-associated bacteria. All of this leads to a production of a biofilm on the vaginal mucosa, in addition to the symptoms that we see with discharge and odor. So I kind of already mentioned this. It is, well, I didn't mention this yet. I'm sorry. So there are some things that suggest that it is related to sexual activity. There are some data to support sexual transmission, but currently it's kind of thought of as a sexually associated infection. You know, one of the most significant risk factors for getting a new case of BV is having a new partner. And then if you have recurrent BV, getting re-inoculated by that same partner is seen as a risk factor. And there's also been studies that my colleague Christina Musney did here at UAB that showed high level of BV concordance in women who have same-sex partners. So we use microscopy again to diagnose this. So in the clinical setting, we use wet microscopy in addition to pH and whiff tests to look for BV. So the 4 criteria for AMSEL are vaginal discharge, pH greater than 4.5, a positive whiff test, which we already talked about, and then the presence of 20% or more of clue cells. So I'll go back to my first slide. This is a good picture of a clue cell. A normal epithelial cell, you see these 3 in the middle that have kind of fuzzy edges. A normal epithelial cell is a nucleus, then a clearing, and then an outline. Here you can see the little studding, the little fuzzy areas of the cells. Those are anaerobes sticking to the epithelial cells and forming that biofilm. So that's a clue cell. So if you're seeing a patient and they have 20% more per high-powered field on microscopy, that is one of the AMSEL criteria. 3 out of 4 are needed for a diagnosis. The sensitivity is very wide-ranging, 37 to 70%. It's very dependent on who's reading it and how the sample is collected. And then Nugent scoring is when you do a vaginal gram stain and look for the presence of lactobacilli, the presence of G. vaginalis, and other anaerobes. This is more used in research settings, but you can see here kind of a colorized version of a clue cell. Basically, when you gram stain the vaginal fluid, you can see all the bacteria sticking to the epithelial cell. There are new novel molecular diagnostics for BV, just like with the other infections we've talked about. It's advantageous over microscopy because it's going to look for specific bacterial pathogens that are associated with BV, and it's less subjective in terms of the reading. It can detect some of these BV-associated bacteria that are harder to see, and you can quantify how much of each type of bacteria you're seeing. All this and all the tests we've talked about can be used, can be run from specimens that are collected as self-collected vaginal swabs. But currently, the 2 molecular diagnostics that we have that are FDA approved can only be used in symptomatic women. You don't want to use these in asymptomatic folks because there's not any recommendation to treat asymptomatic BV at this time. So treatment of BV is similar to Trich. We have metronidazole 2 times a day for 7 days. As I mentioned, lots of people will have 2 infections at once. So I've not uncommonly seen people with Trich and BV at the same time. This is nice because you can give them 1 treatment. However, you have more options with BV. Metrogel is metronidazole gel can be used intravaginally, and it's a 5-day course, and clindamycin cream can also be used. There are several alternative regimens listed here: clindamycin orally, clindamycin intravaginally, secnidazole I already mentioned, and then tinidazole as well. One thing that is not on here is our recommendations for how to treat recurrent BV, which is something that a lot of people struggle with. I actually don't have any slides on it, but I'll talk about it just for a couple of minutes. If you have 3 or more episodes of BV in a year, that's considered recurrent. So just like with VVC, if you put someone on a suppressive regimen of medication, which is typically metronidazole twice weekly for 6 months, it can again prevent that recurrence likelihood. I wanted to just comment on this a little bit. In the current 2021 CDC STI treatment guidelines, they take a stance on this whole association people have had with alcohol and metronidazole, being able to be given together. For a long time, we've said if anybody is a drinker or drinks at all, they should not drink at all or be given metronidazole as a treatment if they even, potentially could drink, because there is a reaction that has been documented in the past, I'm using the name, the disulfiram reaction. However, there have been more recent studies that show that this is not actually a thing that is a result of the two interacting, but more so a result of the alcohol alone potentially causing those side effects, because metronidazole doesn't actually inhibit the enzyme that causes that reaction. So I don't really feel as strongly about recommending that patients withhold drinking. Of course, we want to advise people drink in moderation, but in general, but with the interaction with the medications, it's less of a concern. And then finally, one of the things that's coming is hopefully going to be partner treatment. Currently, we don't recommend this, but it is something that's being studied by several groups. And there have been mixed reviews on these past studies that I show here of its efficacy. BV-associated bacteria, as I mentioned, it's thought that they are transferred from one partner to another, as we could tell from the risk factor of having recurrent BV from the same male partner, or IBV from a new male partner, and then the concordance between two female partners. So the thought is, if it's sexually transmitted and you treat the male, potentially it could be helpful to treat them and prevent the female partner from getting it. But these studies have been not terribly helpful in terms of whether or not that would be effective, but they are doing trials currently looking to see if this could be effective. So stay tuned and keep your ears up for that data. The last few slides are about non-infectious vulvovaginal candidiasis. As I said, I'm an infectious diseases doctor, so I usually focus on infections, but as a good internist, I try to keep a very broad differential. And I really do think about these things a lot, because this is a lot of what I see and end up either trying to manage it myself or sending it as a referral. So dermatologic conditions are a whole talk that I'm not going to go into, but there are many, many vulvar conditions that affect the skin that can lead to a lot of these symptoms that we've been talking about. And I think a few to keep in mind are lichen sclerosis, which are here in this first picture, lichen simplex chronicus, psoriasis, which is in the second picture, and squamous cell carcinoma. They all have kind of distinctive looks, and typically the first two are treated with steroids. The third is treated with other types of immunosuppression, usually managed best by a dermatologist. And of course, squamous cell carcinoma, you don't want to miss. You want to, if you have any suspicion of a lesion when you're doing your exam that could be cancerous, you want to get a biopsy and let the gyne-oncs take it from there. Contact dermatitis is also a common thing I see. People will come and they'll think they have a yeast infection, but turns out they only have an outbreak when they are using a certain type of panty liner, or they're using a new lotion, or they're douching. So one thing when people have irritation or itching as a primary symptom is to do a really good exposure history. You want to make sure that they don't have anything coming in contact with that skin that could be irritating it, especially if you've already ruled out an infectious cause of their symptoms. So I have listed here a few things that have contributed to this. One thing that's not on here is laundry detergent. That's a very common thing that I see. And then tampons, of course, as well. And then the last entity I'll talk about before we open it up for questions is desquamative inflammatory vaginitis. I think in Europe they call this aerobic vaginitis, but it's very poorly understood, as are a lot of vaginal conditions until recent years. It's a chronic clinical syndrome that we don't really know what it comes from, but the primary symptoms are vaginal discharge, pain, and high pH. And it can cause chronic vaginal issues. It's fairly common, but it's usually seen in older non-menstruating people. And the criteria for diagnosing it are pretty specific. So the symptoms, they have to have at least one of these: vaginal discharge, pain with sex, which is dyspareunia, pruritus, burning or irritation. They have to have inflammation. So when you're doing the exam, they need to have like a spotted rash on the vaginal mucosa with some erythema. There's always a high pH in these folks. And then on microscopy, you see a lot of these inflammatory cells, these parabasal cells, which are basically like young PMNs. And then the most important thing is you have to exclude all of these other potential causes of vaginitis. So DIV, as I mentioned, we don't really understand what causes it, but we think that it may be related to some kind of autoimmune process that causes this shedding of tissue and this proliferation of white cells, this inflammation. It's often associated with vaginal atrophy, which is another common cause of vaginal dryness and irritation that I didn't talk about. But we usually treat it with steroids or topical antibiotics here. People don't do super well with this. It's very difficult to get rid of. But if you do see results, they usually see them in about 3 weeks. But I've treated people for like 8 weeks with this. So that's all I have. I wanted to make sure I left time for questions, and I apologize for the little snafu with the slides earlier. So I'm happy to take questions now.
Thank you so much, Dr. Van Gerwen, for your excellent presentation. We will now dive into our live Q&A. So we have time for, let's try to get in as many questions as we have time for. Here, I'm just going to start. We've got some great questions coming in. Let's just start with this one. What are the most important innovations needed in vaginal health to improve outcome among women?
So I've kind of alluded to this throughout the talk, but we have a huge dearth of diagnostics or of treatments in this field. So with all of these conditions, the treatment options are very limited. Every single week when I go to Vaginitis Clinic, I see a patient who has tried everything. And we really have to be creative and try and figure out, logically, theoretically, from the literature that we do have, what makes sense. But in terms of approved and tried and true medications, there is just such a limited array of options. So I think improved therapeutics that are novel and out of class, especially with rising antimicrobial resistance, I think is probably the most important thing.
Thank you. And this question came in a few different varieties, so I'm going to ad-lib it a little. What are the most common issues that you see in clinical practice as an infectious diseases vaginal health expert?
So the things that I think I see the most are bacterial vaginosis and vulvovaginal candidiasis. Probably BV a little more than yeast. So I see referrals for BV all the time, and probably about 70% of the time they're BV, and 30% of the time they're something else. So they're either, physiologic discharge that people are concerned by because they have this discharge. Society tells them they should be clean and smell great and all these things. There's a lot of misogyny packed into some of this in the mindset of medicine. And I think women will come to us and their body will be doing something normal, but they think they're having a problem. So just a lot of vaginal discharge that is normal, but I do a lot of counseling about, you don't need to be putting, douches or fragrances or things up into your body when we can't find a pathologic issue associated with your symptoms. So when I do see BV, that's probably the next most common thing. And then yeast infections are also extremely common.
Very good. And it looks like we have time for one more question. How do hormonal conditions, for example, pregnancy, menopause, gender affirming hormone therapy with testosterone, how do those impact vaginal health?
So that's a great question. With BV in particular, estrogen has a huge impact on the vaginal microbiome. When you have an estrogenized vaginal epithelium, the lactobacillus can grow and be healthy. But when people go through menopause, or an area of interest one big interest of mine is in trans care and the care of gender diverse folks. When you start exogenous testosterone and deplete the estrogen, it can deplete all of that lactobacillus. And so a lot of people who are estrogen deficient or estrogen deficient plus getting exogenous testosterone can deal with discharge, dryness, atrophy, things like that. So the effects of hormones are pretty evident on the microbiome, but we're still really trying to understand as a scientific community the details of how that happens and how we can best optimize treatment for those patients. And then, as I mentioned before as well, when you are pregnant or going through some kind of hormonal modulated process, yeast infections for different individuals are different in terms of how this manifests, but you can definitely see an impact of that as well.
Thank you so much, Dr. Van Gerwen, for your time today and for this important research. Do you have any final comments for our audience? And I believe we have a link we can send out to them as well.
No, I just appreciate the opportunity. I love to talk about vaginal health because I feel like we don't talk about it enough as a society because we're afraid to talk about women's issues, but we shouldn't be because they're issues that are really important and really common. So we need to destigmatize talking about them, and we need to make sure that we are able to be there for our patients. And thank you all who are in industry for being interested in this subject.
Thank you again. And before we go, I do want to thank our audience for joining us today and for their interesting questions. We'd also like to thank our Lab Roots and our sponsor, Thermo Fisher Scientific, for underwriting today's educational webcast. You will notice on your screen right now, you see a link for more information on vaginal and sexual health. Please visit that link below. And additionally, I do want to let our audience know that any questions submitted during the live broadcast that we were unable to answer, and additionally submitted during the on-demand period, they will be addressed by our speaker via the contact information you provided at the time of registration. And before we go, this webcast can be viewed on demand, and LabRoots will alert you via email when it's available for replay. We encourage you to share that email with your colleagues who may have missed today's live event. That's all for now. Thank you so much for joining us. And thank you again, Dr. Van Gerwen. Have a great day, everyone.
Bye. Thanks.